Good morning, good afternoon, and good evening, everyone, and welcome to our webinar titled Respiration in Anesthetized Mice, Evidence-Based Recommendations for Improving Monitoring and Supportive Care. This webinar has been sponsored by Kent Scientific and was produced in partnership with the Academy of Surgical Research, so a big thank you to them both for helping to make this event possible. Joining us today, we're very fortunate to have Dr. James Marx, a veterinarian at UPenn. His presentation will discuss improving the care and use of mice in biomedical research with a focus on the pharmacology behind the effects of anesthetics on respiration. So with that, I'm very pleased to welcome Dr. Jim Marx. Take it away whenever you're ready, Jim.
I'd like to thank everyone for taking some time to listen to this, and hopefully we can make some effort to improve the care for mice that we use in research. One thing I'd like to have everybody appreciate is that most of the stuff we're going to present here, we're really trying to be evidence-based in our recommendations. Evidence-based medicine, using scientific studies to objectively advance medicine has been something that's been going on in human medicine for many years, and veterinary medicine is also picking up with it. We'd really like to start using it in laboratory animal medicine to help improving the care that we give for our animals. When we think about anesthetic monitoring, for most of our mammalian species, there's many things we do to monitor our dogs and cats and monkeys as they're anesthetized. We do things like heart rate and respiratory rate monitoring, ECG, pulse oximetry, end-tidal CO2, blood pressure monitoring. Sometimes we can even get EEG monitoring, which is really helpful. And then the question is, why do we do this? And obviously we do it because it provides valuable information about the condition of the animal. And importantly, that information can lead to a response, something we're going to change in how we're treating that animal to help improve the outcome for this scientific experiment or anesthesia or care for the animal. Which brings us to the anesthesia monitoring of the mouse. And what do we really do when we monitor the anesthetized mouse? Well, it's really little. Sometimes you'll hear people say, well, we monitor the animal continuously. And what that really means is they're just checking to see, is the animal still breathing or is it moving? And if we think about our anesthesia for any of our other mammalian species, this would be grossly inadequate. No one would ever say that we're doing that. But a lot of times that's the care that mice are receiving when they're anesthetized. And we do want you to appreciate that monitoring the mouse is truly difficult. There are many factors that make it really difficult. Most of the time, I suspect your mouse surgeries are not similar to the slide in the upper right where you have a team of surgeons, anesthesiologists monitoring the mouse. It's just a single person who's doing the surgery and monitoring anesthesia and acting as the scrub nurse, which means that surgeon has to consciously stop doing what they're doing, look at the mouse, monitor anesthesia, and then go back to surgery. And when you're in the flow of a surgery, that's a really difficult thing to consciously do. It takes a lot of specialized equipment to monitor the mouse. Everything we described for the large animal anesthesia can be measured in the mouse, just it's much more difficult because of the small size of the mouse. The metabolic rate of the mouse is really high, so things happen really fast. If you have a dog or cat that goes 20 seconds without breathing under anesthesia, you're not super concerned because you know the carbon dioxide levels are elevating, oxygen levels are decreasing, and that respiratory drive is increasing, and the animal will usually start to breathe on its own. If a mouse goes 20 seconds without breathing, he's probably been dead for 10 seconds. So the animals that are most difficult to monitor, things happen the fastest, which means it's really easy to miss important events. Even just a simple thing of visualizing the anesthetized mouse can be challenging because we have sterile drapes. The animal's very small. It's difficult to assess mucous membrane color. And all of these things just make it really hard to anesthetize the mouse. Fortunately, we can monitor the respiratory system quite well in the mouse by using pulse oximetry or just getting a simple respiratory rate. And the question is, does that make a difference, and is it important to monitor the respiratory system? Well, obviously, monitoring respiration is really important in all mammals. In humans, 50% of anesthetic deaths are associated with hypoxia. And if we go into veterinary medicine, There was a paper which recently showed that hypoventilation was the most common complication associated with anesthesia of the dog, happening in about 63% of patients. And that was about twice the rate of bradycardia and hypotension that's seen in dogs. So respiratory problems are a huge problem and certainly warrant our attention. So as we discussed, it is important to monitor respiration, but it isn't unless we can have that information lead to meaningful actions in supporting the animal. There's no point in monitoring an animal unless it gives us valuable information that's going to change what we do moving forward. And so what I'd like to do for the rest of this talk is discuss ways we're going to monitor respiration, the effects of anesthesia on respiration, and importantly, probably the most important thing, what is normal and what are our normal values for an animal that is being anesthetized. And importantly, how can differences from normal tell us to change our actions so we do something to improve the care and outcome of that anesthetic event. All anesthetics depress respiration. And which brings me to the next question is, what does respiratory depression mean? Your first initial response a lot of times is just a decrease in the respiratory rate. However, what it really specifically means is a decrease in the ability to respond to either hypoxia or hypercapnia. Low oxygen or elevated carbon dioxide in your bloodstream should be stimulating an increased respiratory drive and increasing your respiratory rate, tidal volume. If you have respiratory depression, your body does not respond to hypoxia or hypercapnia normally, and it will allow these values to remain high or continue to get higher. A couple of definitions. Hypoxia is just a low arterial oxygen in the blood. It's measured by either pulse oximetry, which we'll talk about in a few minutes, or directly getting an arterial blood sample for a partial pressure. So normal values are 95 to 100% of hemoglobin saturation is normal. But importantly, once you get below 90%, that's indicative of hypoxia. And that 90% on a pulse oximeter reading is roughly equivalent to 60 millimeters of mercury pressure, and that is considered hypoxia in mammals. Hypercapnia is just an elevated carbon dioxide in the blood, and that's measured by end-tidal CO2 or, again, a direct arterial carbon dioxide partial pressure measurement. 30 to 40 millimeters of mercury pressure is considered normal. And once you get up above 60 millimeters of mercury, then it's really elevated. It absolutely warrants a response. Then we think about what can we do in measuring in the mouse? Well, we can't get enough arterial blood to get that analyzed. So measuring arterial blood for partial pressures in the mouse is out. We just logistically can't do that because it requires too much blood from an animal. It's just too small. Measuring end-tidal CO2 is challenging, and we'll talk about that briefly at the end of the presentation. This is a really valuable technique which some anesthesia machines can provide, but we're still really early in measuring end-tidal CO2 in the mouse. As I mentioned previously, mucous membrane color in the mouse is very unreliable. So when we start measuring the respiration in the anesthetized mouse, we're left with the respiratory rate and pulse oximetry. Unfortunately, that can give us some really good information as we move forward. Pulse oximetry is measuring the hemoglobin saturation with oxygen. Normally 95 to 100% of your arterial hemoglobin is saturated with oxygen. There are multiple devices, a few of which are pictured here, which can measure the hemoglobin saturation in the mouse. One important thing to remember, though, is that the relationship between the partial pressure of oxygen in the blood and the percent hemoglobin saturation is not a linear relationship. When you're going from 100% saturation to 95% saturation, that isn't a huge change in the amount of oxygen in your bloodstream. Once you go from 92 to 87%, that same 5%, that's a massive decrease in your in the amount of oxygen in your blood. And you're going from a range up at 92% where you're pretty safe, you're well above being hypoxic, to a range where you're now severely hypoxic. And so this very subtle changes in your pulse oximetry readings can have dramatic differences in what we're seeing in the oxygen status of the mouse. There are several ways that anesthesia will cause respiratory depression. And we'll talk about a few of them here, and we're going to talk about these because there is scientific papers showing that these things are significantly relevant in our mice. The first is that our sensors that monitor oxygen and carbon dioxide are depressed with anesthesia. We think about it, the oxygen sensors in the body are primarily located in the carotid bodies, which are located in the bifurcation of the carotids. And they will typically respond when oxygen tension is low, below 60 millimeters of mercury pressure, or around 90% hemoglobin saturation. And that is considered our hypoxic drive. So when our oxygen drops very low, below 90% hemoglobin saturation, the carotid bodies start to fire, sending signals to the brain that we need to increase the respiratory drive. Unfortunately, the activity of the carotid bodies is suppressed by inhalants, benzodiazepines, opiates, many of the anesthetics that we use. Carbon dioxide and pH, which are closely related because of the buffering of bicarbonate, that's sensed more primarily by the central chemoreceptors. About 2/3 of the response is from chemoreceptors that are located up in the medulla. The carotid body does have some sensors responding to pH and carbon dioxide. And the central chemoreceptors, unfortunately, are also sensitive to the anesthetics, with anesthetics depressing their action. Ultimately, the peripheral sensors are more sensitive to anesthetics than the central, meaning that animals at a lower anesthesia plane will lose their responsiveness to hypoxia faster than they will lose their responsiveness to an elevated carbon dioxide. However, as we'll see in a few minutes, at higher doses, all of the activity of these sensors is significantly depressed. Another reason we have respiratory depression is because that anesthesia suppresses the action of the respiratory muscles. There are two main groups of respiratory muscles, the upper airway dilator muscles and the respiratory pump muscles. And these muscles have to work in very coordinated activity together. If the respiratory pump muscles are active, they create suction within the chest. If the airway dilator muscles are not active, the upper airway can close down, cause an obstruction of breathing. So having these things coordinated is very important. Also, as we see when we look at the graph, many of our anesthetics affect motor neuron function. So these muscles are inhibited during anesthesia. So we not only have a decreased input from our sensors, but our response at the level of the muscle is depressed. So we're just not getting a good response to normal signals to increase respiration. The third factor I'd like to discuss is atelectasis, which is simply a collapsed lung. In some estimates, 90% of anesthetized humans have some atelectasis in a portion of their lungs. And this is simply because the lungs are not being used. The pressure within them is inadequate to keep them inflated. In humans and large animals, we can use positive end expiratory pressure to keep a little pressure in the airways to help keep our alveoli inflated. And we can also do recruitment maneuvers like a sigh periodically, which will help inflate the alveoli so that they stay open during the procedure. Unfortunately, these all require intubation in order to be forced air in there and not just let the air escape out and have the pressure drop back to normal. Typically, we don't intubate mice. We certainly can intubate mice, but as we talk about routine surgical procedures in mice, most mice aren't intubated, so we're going to have real problems with atelectasis. And not surprising, there's been a couple studies that have shown that atelectasis is definitely occurring in our anesthetized mice. And it isn't just the atelectasis during surgery. Atelectasis has been shown to be associated with an increase in inflammation after surgery. So this atelectasis is not a trivial concern in our animals. There are other mechanisms that are associated with respiratory depression. which have been shown in humans and other large animal models. I have not seen direct evidence of these in our mice, so while I suspect they happen, I really don't have evidence supporting that. So these are all theoretical examples of potential ways that respiratory depression could be affecting the mice. So the question you may ask yourself is, my mice survived surgery, so why should I change? And we'll probably modify that to at least the vast majority of my mice survive. Mouse anesthesia has a very high death rate compared to our other species. Human death rate associated anesthesia is about 1 in 100,000 events. Will never be as good as humans, but in dogs and cats, it's between one death in every 500 to 1,000 events. In surveying people, the death rate in mouse anesthesia is about 2%, so it's an order of magnitude more than we have in our large animal species. Now, maybe that's the best we're going to do. However, unless we start trying to advance our mouse anesthesia and bring it up to the standards we have for our large animals, we really won't know if we can't do better. So what I'd like to do for the rest of the talk, as I mentioned before, is I'm going to try and convince you that your mice not be as stable as you think they are when it comes to their anesthetic plane, particularly looking at the respiratory values. And we're going to show you that some of the values are going to be predictive of impending problems, and there are actions you can take to help prevent these negative events. Going back, the definition of respiratory depression was inadequately responding to hypoxia or hypercapnia. So I'd like to take a look at a few studies which have shown that the mouse is not responding to either an elevated carbon dioxide or a depressed oxygen. In this study, which was done a few years ago, groups gave either isoflurane or ketamine xylazine anesthesia, and then exposed the mice to increasing concentrations of carbon dioxide. And what we know that's going to do is that's going to elevate the arterial carbon dioxide and should make the animal breathe very much more heavily. In the graphs on the left, the lower two are the respiratory rate and the tidal volume, and then those are summed together to give you the minute volume, which is the graph on the upper left. And as you can see in the control condition when the mice are awake, as you expose the mice to increasing carbon dioxide concentrations, you get increase in respiratory rate and tidal volume, and subsequently a large increase in the minute volume of respiration of the mouse. However, the isoflurane at 0.5 and 1%, which is concentrations which are going to get you nowhere near a surgical plane of anesthesia, those dramatically suppress the respiratory response, meaning that those low levels of isoflurane really suppress the animal's ability to increase respiration as carbon dioxide increases, and shows us that our anesthetized mice probably have really high levels of carbon dioxide, which is really difficult to measure in mice, but certainly can be done. The same can be said for ketamine xylazine anesthesia, which is the 4 graphs on the right. Again, the bottom two are respiratory rate and tidal volume, and those combine to form the minute volume, which is the graph on the upper left. Again, under the control conditions, increasing carbon dioxide leads to a big response and increase in respiratory rate and tidal volume. However, when the animals are anesthetized, again with anesthetic planes, which are inadequate for a surgical plane of anesthesia, the response to that carbon dioxide is dramatically impressed. We see very small increases in respiratory rate, very small increases in the tidal volume, and subsequently very small volumes in the minute volume that the mouse is exchanging. Both of these are showing that in isoflurane and injectable anesthetics, both primarily ketamine xylazine, which is what most people use for their injectable anesthesia, our anesthetics are dramatically decreasing our response to carbon dioxide. This is a paper we did which looked at pulse oximetry and oxygen supplementation. And I'd like you to, the panel on the left is a mice receiving just ketamine xylazine at a dose which will immobilize them, very similar to the previous study. Panel B is mice that are anesthetized with ketamine, xylazine, acepromazine, which would bring them to a surgical plane of anesthesia. The bottom two lines on each graph are the pulse oximetry readings, and half of the mice received oxygen supplementation and half didn't. When the mice receive oxygen supplementation, it means their pulse oximetry readings remain at about 100%, which is perfect. If they don't get supplemental oxygen, they're just breathing room air, which is really the typical state for most anesthetized mice. Their pulse oximetry readings were only at 60 to 70%. And interestingly, you can see in the line above those is the respiratory rate, and we don't see a big response in increasing respiratory rate to the hypoxia. With oxygen levels that low, we would certainly expect a strong respiratory response in an awake animal, but the anesthesia has suppressed the response to oxygen, and we're seeing this dramatically lower response in respiratory rate to hypoxia, which is really our definition of respiratory depression. We then did the same thing using isoflurane, and the difference here was either the animals had 100% oxygen as the carrier gas or 21% oxygen in compressed air. With the 100% oxygen, it maintained the mice at 97% hemoglobin saturation, which is ideal. And when we used 21% oxygen, it was only 80%, approximately 80% hemoglobin saturation, which is really low. If we go back and look at our respiratory depression and our pulse oximetry readings, if we look at the table on the right, which is related more to humans, we can see 95 to 100% is normal. And that's where, when we have our animals supplemented, our animals' hemoglobin saturation is at these very high levels. Once you start to get into the low 90s, it becomes very worrisome. Once you get in the 80s, we see that it starts to affect brain function. And if you remember, the mice in our studies were between the 60s and 80s. So they're in a range where we're definitely going to be affecting the brain activity in anesthetized mice. And this will have effects during the anesthesia and may well have long-term effects for behavioral studies after the anesthesia. So our mice that are routinely getting anesthetized, which seem to recover, are really having profound hypoxia, and it may be affecting some of our other studies. Another thing that we have to think about as researchers is that hypoxia may be affecting our animal models. And here's a case where hypoxia actually treats a neurodegenerative disease in a mouse model, which is the exact opposite of what you'd think. Normally, you'd think hypoxia would make things worse. However, if our animals are becoming hypoxic, it may well be affecting the phenotype of our animal models, which is certainly something we can't have because we need to know, exactly what's going to happen for our animals to produce valid responses. So we've shown that our mice who are anesthetized are experiencing significant respiratory depression. But the question is, does monitoring and supplementation of oxygen help make a difference? Because really we need to show that monitoring and supplementation will, one, prevent animals from going too deep, or prevent them from becoming not deep enough, allowing them to wake up and experience consciousness under anesthesia, which of course is a huge animal welfare concern. Now, one of the most important things I'd like to have people take away from this talk is just what is a normal value for an anesthetized mouse for a respiratory rate. If we're going to, we need to know what normal is so we can really see what abnormal is. And importantly, it really depends on the anesthetic you're using. These are results from a couple studies we've done over the years. And in the panel on the left is the normal heart rate and respiratory rate for mice, healthy mice anesthetized with 2% isoflurane. On the panel on the right, the mice are anesthetized with ketamine, xylazine, ACE. And in both cases, the animals were at a surgical plane of anesthesia, a very safe surgical plane of anesthesia. So it's comparable between the two. So it isn't that one group is significantly deeper, at a deeper plane of anesthesia. And if we look at respiratory rate, we have the mice anesthetized with 2% isoflurane. Their respiratory rates are typically less than 100, and they're going to spend most of their time around 60 breaths per minute. When we look at the ketamine, xylazine, acepromazine mice, and this goes for our other injectable anesthetics that we've been testing, the respiratory rate's about 150 breaths per minute. So it's really important to know what normal is for the anesthetic protocol we're doing. Because if we have a mouse that's breathing at 60 breaths per minute, if he's on isoflurane, that's perfectly normal and acceptable. As we'll see in a few minutes, if he's at 60 breaths per minute and he's anesthetized with an injectable anesthetic, he's in really, really extreme danger of having problems. So what I'd like to do now is talk about what information can we derive from monitoring respiratory rate. Now, this is a different study where we tested repeat bolus dosing of anesthetics. And what we found is that many of the mice, if we redosed them too early, died from the anesthetic redosing. The goal was to extend the surgical plane of anesthesia in the mice, and we were trying to determine when is the ideal time to redose them. And if we found that if we redosed them while they were still at a surgical plane, we had really, really high mortality. Fortunately, we were able to monitor respiratory rate and heart rate, and so we could form really good assessment of these values in mice that either survived or died the anesthetic event. In the panel on the right, you can see there's two sets of lines. The top is the heart rate, and the black curves are the mice that survived. The red curves are the mice that died. As I said, the one on the top is heart rate, and the one on the bottom is respiratory rate. In the mice that died, when you monitor the heart rate stayed very consistent and normal right up until the time of arrest, and then it crashed very suddenly. The opposite of that occurred with respiratory rate, where it gave us a really good prediction that the animal was going to arrest. And as you can see, with our C57 Black 6 mice, 120 breaths per minute was very predictive of death. Any mouse that went below 120 breaths per minute ultimately died, and all of the mice that stayed above 120 breaths per minute survived. So that's a really good indicator of an impending problem. And if you're just looking at the mouse, monitoring continuously, but not taking a respiratory rate, you won't get this information. You have to consciously stop and get a respiratory rate. The next question is, how frequently should you be monitoring the respiratory rate? And in the same study, and we didn't publish this data, this is an analysis we've done after the study, if you monitor the respiratory rate every 10 minutes, you'll catch about 40% of the mice which will have an impending respiratory arrest. If you monitor every 5 minutes, you catch over 80% of these mice. So monitoring them every few minutes is really, really imperative. If you want to catch the vast majority of mice, the respiratory system is giving us the clues that impending arrest is coming. And if you're monitoring frequently enough, you can catch these events and be able to have an intervention, which we'll talk about in a minute. The other thing to be aware of, it only takes less than 20 seconds to get a respiratory rate. If you have a clock sitting beside you with a second hand, what I'd suggest doing is count 10 or 15 breaths and then measure how much time it takes to take those breaths. If the mouse with isoflurane is breathing about 1 breath a second, you're at a pretty good point. If the mouse on injectable anesthetics is breathing faster than 2 breaths per minute, you're okay. Once these values start to drop, and the respiratory rate for C57 Black 6 mice goes below 120 breaths, then you may well be having a problem and it's time for an intervention. Other strains of mice will probably have lower values, but again, as you do your experiments with your particular strain of mice and all their genetic manipulations, you will start to see, as mice survive and die, what the values predictive of death are for your specific strain of mouse. Now, the resident who did this project eventually got tired of watching his mice die, and he was able to identify that none of the mice, once they became agonal, survived. However, in the last 7 mice that became agonal, he treated them with atipamezole to reverse the xylazine anesthesia. And even though the animals were agonal, the arrest process was well into it, heart rate had crashed, giving this intraperitoneally, he was able to save almost half of the mice by treating them with atipamezole. And I would believe that if you catch the mouse even earlier, before he's got all the way to arrest, while his respiratory rate is dropping, and treat them earlier, you'll get even better results. Now, one thing to really be aware of is that you need to be prepared for this, because you can't identify that the respiratory rate is dropping and then have to go find your atipamezole, draw it up, figure out a dose, and then give it, because by then it's way too late. But if you're prepared, you have it with you, you have a dose in your head, as you start to see that drop, you act then, I think we'll have a much higher survival rate of our mice, which may well be dying, if we intervene early, just by monitoring the respiratory rate. Monitoring SpO2 also provides really valuable information. In this panel, these are the heart rates, respiratory rates, and SpO2 values of mice which received a really high dose of ketamine, xylazine, promazine. The doses were 150, 12, and 3 mg per kg of each drug, which is very, very high doses. All 4 of the mice that received the drug without getting oxygen supplementation, as you can see, that's the very lowest line there. Hemoglobin saturation was only about 50%. All of those mice went on and died, which is telling us that if your SpO2 is in the 60 to 80% range, it's not good, but your mouse has a reasonable chance of surviving. Once they get down into the 50% range, you're pretty confident that mouse is going to die, and you need to do something about it to help prevent him from dying. Which means, what are you going to do? And supplementing oxygen is really potent, because in the same study, we had the same anesthetic dose, but then we gave the mice 100% oxygen support while they were anesthetized. And as you can see in the second line up, those mice maintained SpO2 values of 95 to 100%. And while all 4 mice died if they did not receive oxygen support, all 4 mice that did receive oxygen support did survive. So it seems kind of common sense that if we provide oxygen support, it's really going to help the survival of our mice. But this is a study showing very clearly that it does help increase the survival of mice. And it is because we can't tell exactly which mouse is going to overreact to injectable anesthesia. Providing supplemental oxygen to all of mice is a really, really good idea. If you don't provide to all of them and you monitor SpO2 values, if that SpO2 values start to go below the 60s and 70s and get into the 50s, that's a strong indication that death is coming. But it'd just be better to supplement all of the mice with injectable anesthesia, which is not a common practice. Most of the time we anesthetize the mice and we just let them sleep without any kind of supplemental oxygen. Going on, it'd be nice to say that we can use our monitoring to assess things beyond just, is the mouse going to live or is the mouse going to die? And to do that, we need to talk about different planes of anesthesia, and can our respiratory monitoring help differentiate between these different planes of anesthesia? So I'd like to talk for a minute about this graph, which is a graph I love because it applies to all species and it applies to all of the anesthetics that we commonly use. On the x-axis is just increasing doses of the anesthetic, and the y-axis is the percentage of mice achieving some plane of anesthesia. The first thing you lose when you're at your lowest planes of anesthesia is memory. So at very low doses of anesthesia, you lose memory. The next thing you lose is consciousness, which is really important, because if you are unconscious, you cannot experience pain, which of course is a huge part of anesthesia, is prevention of pain. The third thing you lose is no movement in response to a noxious stimulus. And in veterinary medicine, that's what we define as the surgical plane of anesthesia. That means that when you do something painful to the mouse, there's no motor response to that painful or noxious stimulus. The next thing you lose is blunted autonomic reflexes. And what that means is that you've anesthetized the animal so deeply that he no longer has his autonomic reflexes to changes in his condition. So if the animal starts to bleed or something starts to happen, it's totally up to the surgeon and the anesthesiologist to correct it. We can no longer rely on the autonomic reflexes of the animal to help keep the animal alive. Ideally, we'd like to have that animal so he has no movement response to a noxious stimulus. However, he still has his autonomic reflexes intact. So it'd be great if we could find a test which could confirm where we can do a noxious stimulus and still see an autonomic response to that noxious stimulus. We are in the process of doing a study looking at an anesthesia protocol, looking at dexmedetomidine, midazolam, and buprenorphine. And in that, we are doing our standard noxious stimulus, which is we use a 300-gram touch test device to stimulate the hind feet. This works really, really well for mice because we get a good withdrawal reflex, but it doesn't do any long-term damage to the mouse. Our mice don't wake up being sore or anything like that. If we do that test and there's no movement in response to that stimulus, then the mouse is at a surgical plane of anesthesia. And if he has a muscle reflex twitch when we deliver that force, then we know he's too light and he's not at a surgical plane. Ideally, there will be no movement to that, but we want the autonomic nervous system to still respond to it. And we've looked for trying to see if there's an increase in heart rate or respiratory rate with several different anesthetic protocols. We just really haven't been able to find anything reliable. However, with this study, we have found that in our mice, which we are not supplementing oxygen, their SpO2s tend to be in the around 70%. We can see a reliable, statistically significant transient increase in the SpO2 to our noxious stimulus. What that means is this animal is really at a surgical plane of anesthesia where we want him, where he's not moving in response to our noxious stimulus, but his autonomic system is sensing it and changing how the animal's acting. So we know his autonomic nervous system is still functional in response to that noxious stimulus. And that's right where we want him to be. And so, we haven't been able to see that in heart rate, respiratory rate monitoring, but if we look at this SpO2, we can see a very nice increase of 3 or 4% for a few seconds, and it comes back to normal after the noxious stimulus is over. And that's really telling us this animal's at a really safe plane of anesthesia for surgery, and death is not impending and going to happen soon. As we move forward in the field of mouse anesthesia, there's several things that we'd like to address in the future. One is increasing the use of end-tidal CO2. As I mentioned earlier, this is a really valuable test, which will tell us how much carbon dioxide is in the bloodstream and will give us an indication that the animal is ventilating normally or if his carbon dioxide levels are elevating. This is a really challenging test technically for companies to develop because you need to be able to measure the carbon dioxide with each breath of the mouse. And mice are breathing, as you can see, very rapidly. Their tidal volume is very small. So this is a really challenging thing to develop. Kent Scientific has an early model with one of their anesthesia products, which is starting to bring us to where this may become a viable option in the future. Another thing to think about as we move forward is we've talked about giving 100% oxygen supplementation. In humans, they rarely ever give 100% oxygen because they're worried about oxygen toxicity and inflammation associated with oxygen. At this point, dog and cat veterinary anesthesiologists still are using 100% oxygen. The anesthesias we do in animals tend to be much shorter because humans, they'll anesthetize for many, many hours. I think we're going to lag behind the dog and cat veterinarians as to when should we start thinking about using 50% oxygen instead of 100% oxygen. But this is something we'll think about down in the future. And at this point, really, if we want to stick to the evidence-based medicine, we really don't have any evidence-based medicine to change our recommendations at this point in time. Of course, moving forward, heart rate and blood pressure monitoring, while both challenging in the mice, do provide really valuable information as we monitor our large animal species. And as devices come available, remember your pulse oximeters give a heart rate quite nicely. There are other ECG machines specifically developed for mice, which give a very accurate heart rates, can also tell us about arrhythmias. And these are things that we can add to our respiratory monitoring. But at this point in time, really the respiratory monitoring is something we can do affordably, and as hopefully we've seen, will make a difference in what we're doing. In conclusion, there is no perfect anesthesia protocol, and monitoring our mice is always going to be really important, just like we monitor people. There's no perfect anesthesia protocol for people, and there's certainly none for dogs or cats or mice, where we can give the drugs, forget about it. 100% of them wake up and do fine. However, as we talked about for the last hour, hopefully you'll appreciate that mice aren't as stable as we may be thinking they are. The ignorance is bliss may not be a good idea here, because if we start looking at respiratory function, we start looking at blood carbon dioxide levels, oxygen levels, we'll see they're shockingly low. Values which, if you had those in a dog or a cat or a monkey, would really stimulate action, but we aren't responding in mice because we really don't know and appreciate that they're there, and we probably should know and start acting upon them. The monitoring does give us valuable information because it can tell us which animals are at real risk of a cardiac arrest or respiratory arrest under anesthesia. And importantly, when we get that information, there's things we can do to help prevent the arrest. Either reversal of the anesthesia, supplementing oxygen, stimulating the mouse. These are things that we can do which will ultimately make a difference in that anesthetic event for that animal. I'd like to thank the many people who I've been able to work with projects on here at UPenn. I've had the great opportunity to work with a lot of really good residents here who've collected a lot of really spectacular data in mouse anesthesia, and I really, really appreciate that. We've had a chance to collaborate with some of the professors in anesthesiology at the medical school, as well as at other institutions across the country. And lastly, I'd like to thank Kent Scientific and the Academy of Surgical Research for helping support this talk and letting us deliver it. And I'd really like to thank the people listening and hopefully allow us to move forward and improve the care we give to our anesthetized mice.
Thank you for that presentation, Jim. It was really fantastic, and we have a ton of questions here. Let's kick off this Q&A. So if you're ready, the first question here is, would you suggest doing a pilot experiment with new animal models or knockout mice where you don't know their quote-unquote arrest threshold to determine that threshold?
Yeah, that's a really good idea because there's so many variables that are going to affect the amount of anesthesia and the type of anesthesia that's going to be best for your experiments. We genetically breed mice to be different. So while we may be affecting a protein that we think is just going to be in the liver or just be in the immune system, we really can't be surprised when, lo and behold, it has effects on the anesthesia, responsiveness to anesthesia that we're giving. So there's a lot of variability there. In our animals, our different strains of mice have been bred to be different. Also, the person doing the surgery is a profound variable that's going to affect things. If you have someone who has really extensive mouse surgical experience, they're probably going to be much quicker with the procedure. They will probably also have much less surgical stimulation or painful stimulation than someone who's doing this for the first time or doesn't have much experience. And we're going to need to give more anesthesia to that when that person doesn't have much experience. So there's several variables to consider. So getting a baseline of a couple pilot animals to make sure that the animal is in that ballpark range of what we're expecting is a really, really good idea.
Mm-hmm. Fantastic. Yes, definitely. You want to shorten that procedure as much as possible. Okay, so this next question here is, while adequate ventilation is critical, respiratory patterning and cardiorespiratory coupling are also impaired when using inhaled anesthetics. Do you have any guidance for minimizing these confounders?
Really, no, I don't. And I'd love to. As we do our experiments, we see respiratory patterns that are different, but it's really difficult to draw a really good assessment until the changes are really profound. I think you're going to find that the patterns of breathing are very different in your inhalant anesthetics, where they are going to be much more intermittent, and you're going to see much more deep breaths associated with your inhalant anesthetics, whereas the respiration, when you're giving your injectables, tends to be much more shallow and as we've discussed, much more rapid. but it tends to, in my experience, and we've never tried to quantify this or really been able to quantify this, it tends to be a much more smooth transition when you're going from awake to a surgical plane of anesthesia with your injectables than with your inhalants. Because sometimes with your inhalants, you got to keep an eye on the mouse, and you're kind of wondering, is this normal? And the vast majority of the time, it does settle out to a nice and steady respiratory rate, usually somewhere around 60s, as we've discussed. Once you start to see really significant changes in the respiratory pattern, of course, just like with our other species, that's a really advanced sign. And certainly once things start to get to where they're agonal, then that's obviously a really advanced sign. As far as cardiovascular monitoring, we are doing ECGs in our anesthetized mice. Some of the mice occasionally will see VPCs or atrial premature contractions, but we've never really tracked down any that are significantly worth considering treating in mice that have survived. But we're pretty new to a lot of the ECG analysis, and we've been doing it mainly with our inhalants. So with our injectables, we really need to look a little bit more in detail on that. But as far as the cardiovascular patterns, I don't have a lot of information on that at this point in time. And unfortunately, ECG monitoring in an anesthetized mouse, it takes specialized equipment, and it is much more challenging. So I don't think that's going to be something that most labs are routinely doing for their anesthetized mice.
Mm-hmm. Okay. The next question here is, well, I'm going to combine two questions because they're kind of similar. So the first part of this question is, do you have resources for the quote unquote normal values for heart rate and respiration rate for rats under anesthesia, inhalant and injectable?
No, I don't, but it's interesting to me because here at UPenn, I expect most universities, we've shifted away from rats, so we have surprisingly few rats on campus. We definitely have a few rooms of them, but I have much less experience with that. There are several rat papers, and I know Shalala Pacharzak at Stanford has done a lot of papers with rat anesthesia, and I expect those would have normal values for the rat. But I expect the trends of having a lower respiratory rate with your inhalants than your injectables is something that will hold up across species. It's just much less noticeable as we get to the larger species because the rates are all going to be lower, in your dogs and cats and monkeys. So seeing that big difference between the respiratory rate with your anesthetic protocol will be take more of a subtle analysis.
Mm-hmm. Yeah, definitely. And definitely something to consider for future studies, for sure. Okay, the second part of that sort of question is all of the things that you mentioned in your presentation for monitoring mice. Are these recommended for rats as well, or should people using rats or like larger rodents be considering using another monitoring method?
The closer we can get to what we currently do for dogs and cats, the better. One of the advantages for rats is that some of the pulse oximetry devices which we use in our dogs and monkeys, the rat is large enough that those are effective when anesthetizing a rat. Most of those devices, when we try and use them on mice, just aren't effective. So we really found that we really need to use a mouse-specific pulse oximeter in the mice. Things like blood pressure are really hard to get in your rodent species because they don't have a limb which can easily get a cuff for plethysmography readings and that kind of thing. Also, that if you're starting to think about trying to get a direct arterial line into them, that's much more challenging. So again, I think the pulse oximetry and respiratory rate monitoring are pretty readily available in the rat. But once we start to get into some of the more subtle things, like blood pressure monitoring, it's challenging just finding a device that can accurately measure that in a routine setting. The other thing is, again, end-tidal CO2, which again, there's some devices which can do that in the mouse, and could also do it in the rat, I assume. But the problem is most of the time we don't intubate our rats, so getting really accurate values with that will be challenging. But as we move forward and companies develop more of this technology, that certainly is something that we can hopefully develop in the future. But for rats now mainly, I think we're for routine situations. I think your pulse oximetry, respiratory rate, pulse oximetry also gives us heart rate. Is probably the best we're going to do unless your lab is going to invest in some specialized equipment.
Yeah, definitely. Sometimes specialized equipment is required, especially for cardiac stuff, but especially if you're doing something like injectable, it becomes a little bit harder to justify for sure. Okay, this next question here is an advice question. They're asking, at what point do you extubate your mice and stop providing supplemental oxygen? So I guess like how long after the procedure or during the procedure?
Our studies are designed to model mice that are being routinely anesthetized. And here at UPenn, and I assume in most institutions, mice aren't getting routinely intubated. So we don't typically intubate our mice for our studies. With most species, once the animal starts to chew or becomes awake, then you're going to be intubated, removes the tube. That'll be a little more challenging in the mouse because their teeth are so sharp that they could easily break off that tube. So I don't have a lot of experience or information to give on extubating mice. But it is a procedure that once you do it a few times with a little practice, is certainly something that can be done pretty routinely. If your lab wants to invest the time in learning how to do that, or if you want to really protect the airways, that it is a really good procedure to be able to do.
Mm-hmm. Yeah, and there are some tools that help with that and learning that procedure quickly and efficiently.
Yeah, there's some really nice kits which will help make it quite easy. And like with every procedure, the first few doesn't go too smoothly, but after a little bit of practice, that can be quite a routine procedure.
Yeah, definitely. Especially in mice, it is a skill that you must practice. Okay, this next question here, a lot of people have had this question, so that's why I want to address it. For supplemental oxygen, would you recommend 100% O2 or 21% O2, which is just room air? And for delivery of isoflurane, there are some anesthesia machines that use room air for delivery versus tank or concentrator oxygen at differing percentages. What is your strongest recommendation for mice specifically?
Yeah, our recommendation is 100% supplementation, whether using injectable or gas anesthesia. Many of the facilities here at Penn use 21% compressed air as the carrier gas. And as we saw in our studies, those mice are profoundly hypoxic. Hypoxia that's profound enough that if we saw it in another species, it would kind of make us freak out. We usually don't know that it's happening in our mice, but if we can supplement them, just about all of our mice go up to the 95 to 100% pulse ox readings and are quite stable. So yes, I don't think supplementing with 21% oxygen is going to, we know it doesn't help with the with using the inhalant anesthetics, and I don't expect flowing by 21% oxygen in a mouse which has received injectable anesthesia would make a meaningful difference other than just them inhaling the 21% oxygen. So if we're going to take the time to supplement them, I think 100% oxygen is the way to go. If there are some procedures are very, very long procedures, and where you may start to think about is oxygen toxicity a possibility. Under those cases, much as they would do in humans, I think 50% oxygen may well be a suitable substitute for that to prevent that. I don't have any experience with 50% oxygen, but I expect that would do a pretty good job at elevating the pulse ox readings of the mouse and keeping them out of that dangerously hypoxic range. And keep them up in the 90s for their pulse oximeter and above the 60 millimeters of mercury oxygen tension in the blood. So, so I think 100% oxygen supplementation is the way to go. And that can be challenging if you're doing longer procedures or MRI procedures where you can't bring an oxygen tank in, conveniently. Then you're having to have the tubing to deliver the oxygen from outside the room into the animal while it's in the imaging modality. But I think what we saw, even at low doses of anesthesia, they are shockingly hypoxic and would definitely benefit in their survival by supplementing oxygen.
Mm-hmm. Definitely. And I think also the flexibility of being able to choose between room air and any sort of compressed gas at whatever percent oxygen you choose is kind of a nice feature or a nice option to have. Gives you a little bit more flexibility. Okay, we are just over, but I want to do one more question, so hopefully people can stick around. This last question is about injectable anesthesia. So this person has asked, what is the best route for atipamezole? Atipamezole IV is contraindicated in larger species due to profound hypotension and is labeled for intramuscular, but since intramuscular is not so commonly used in mice, does IP administration cause the same type of hypotension as IV? And is sub-Q administration too low?
In the study that we discussed during the talk, we delivered the drug intraperitoneally because we needed a really rapid effect because these mice had already progressed to becoming agonal. So when they were that far advanced, we didn't think that sub-Q administration would be nearly adequate to get the response. For routine administration, we don't give anything IM in mice because the muscle mass is so small. For routine, I believe we typically go subcutaneously. You have to be a little bit careful with atipamezole not to overdose them with that because we have had problems in the past. Now, we don't routinely monitor blood pressure, so I don't know that it was directly due to blood pressure. But the dosing, and I don't remember the dose of atipamezole we used off the top of the head, but it's in some of the lab animal formularies. It is a fairly safe, conservative dose that you can give safely. And I believe sub-Q, if it's not an emergency procedure, would be adequate to get the animal going after the anesthetic event. But in an emergency situation, we gave it intraperitoneally because you really need that response. And I don't think we could reliably hit the veins of a mouse who's undergoing cardiac arrest or profound bradycardia or something like that. We never even tried to hit the veins in those mice because it's hard enough to get an artery or a tail vein injection in a mouse when they're awake and conscious. When they're arresting, I think that would be really impossible. So intraperitoneally is the way we go in an emergency.
Mm-hmm, definitely. That makes a lot of sense. Okay, well, I just really wanted to thank you, Jim, for all of your insights today. It really was a pleasure to have you with us.
Thanks very much for your time, and I really appreciate people listening and signing in so that we can slowly start making some headway. And we really want to hear about your experiences with mouse anesthesia, what works for you, what doesn't, and what your opinions are.